There's the bio that has her.
Yeah.
Also. Oh, got it. Okay, great. I just saw that top. Oh, he doesn't have those recently.
Okay, why don't we go ahead and get started. Want to welcome everyone to our Thursday conference, and actually today is one of the days we're also designating as an IDL talk, which, as many of you know, is our Informatics Discovery Lab, our new initiative that's looking at trying to build bridges, collaboration to industry and others outside the university. Kind of spread the word of informatics. And part of that effort is also tied into a larger OHSU effort, which is to try to get more interaction between these two great organizations that exist in the Portland area, which are OHSU and Intel, about 10 miles apart, but until recently, not just occasional bits and pieces going on. So to that end, we have started engaging those working in healthcare at Intel, and so we're going to start to involve them in some of our IDL efforts. And so our first effort in that regard is today's talk, and we have Nancy Vuckovic, who some of you know because she has worked over the years with Joan and others in the department, so she's no stranger to DMICE. But anyways, she's currently medical anthropologist and director of user experience research in Intel's Health Strategy and Solutions Group, and her research involves studies of clinician mobility in hospitals, delivery of home-based primary care, and experiences of patients and family caregivers during care transitions. And she currently leads a team of ethnographers and user interface designers in the U.S., England, and China. Before joining Intel, Nancy was a PI at the Kaiser Center for Health Research, where she developed and led health services research studies and clinical trials of behavior change interventions and alternative therapies for pain management. Nancy has a PhD in medical anthropology from the University of Arizona, and also from Arizona a MA in linguistic anthropology. So I will turn it over to her.
Thanks, Buddy. Sorry if you missed that first bit. But we've been involved in healthcare for a number of years at Intel. A lot of people are like, wow, Intel's doing healthcare? But actually, we've been engaged in healthcare research and design of interventions for over 8 years. Most of that early work was focused on aging in place technologies, things like sensors to detect falls and changes in gait, as well as devices that might help elderly people to stay in their home a little bit longer. We're still having a thread of that, but more recently, we've been working on strategies that are really clinical in focus. So rather than personal health care kinds of things or even aging in place, we've been focused on ways that we can help clinicians to be more effective and to really enjoy their jobs more, you might say, not unencumbered by technology as it exists today. So we have sort of a large group, which is called Health and Life Sciences, which deals with a lot of different kinds of aspects of healthcare, including working with partners like GE and others to develop technology that enables things like tiny ultrasound machines and other kinds of stuff. But our particular group is called Health Strategy and Solutions. And we're really focused on trying to find solutions in the clinical space, things that will help clinicians do a better job, as I mentioned. We're also involved in research that looks at big data and genomics, and I'll talk about some of the initiatives that we have in just a moment. But our basic approach to healthcare in general in our group is to do research, some of which I'll describe to you, others that are a little more clinical in focus because we partner with a variety of different institutions to understand clinical space. We incubate new ideas. We try to come up with solutions, and then we will test them out. We might make either concept prototypes that are really more like storyboards and test them out with people. And we also work with other partners within Intel to create actual functioning prototypes that we could bring before clinicians. And we're working with OHSU on some of those things right now in terms of using the new sim lab when it gets developed to bring those kinds of interventions to people and try them out. We also are involved quite a bit in thought leadership. So it involves things like this, coming to talk to different groups, talking at conferences, publishing papers in peer-reviewed journals. We try to, as much as possible, make the work that we do and the research that we do transparent to a larger audience. Some of it, of course, is proprietary, but as much as possible, we can. So, for example, research that I'm going to touch on briefly today that we did with the Veterans Administration, we just submitted to Health Affairs yesterday, finally. So we really try to get out the information as much as possible. And then we're also involved in, the bread and butter, the earning money for Intel, which is the go-to-market piece, which is helping Salesforce become trusted advisors when they go out and talk to healthcare clients. So the work that we do, our understanding and deep knowledge of the healthcare environment and clinical space helps people make suggestions about the kinds of technologies that might be useful to people in both enterprise settings like OHSU and other large hospital systems, as well as smaller organizations as well. So I'm going to go over a couple of the initiatives that we have going. We try to focus our energies. We're a rather small team. We're based primarily in Oregon, a few people in California. We've got some folks in London and in Beijing, but it's still a pretty small group of under 50 people trying to get a lot of work done. So we're trying to focus our efforts as much as possible. And one of our big initiatives is healthcare mobility. Understanding, I'll talk about this more when I get into the research piece, but understanding that our society as a whole, our world as a whole, is more mobile in terms of how we access information and where we do our work. And how can we bring the healthcare enterprise into that space to enable people to work in remote areas, providing care, or even to be able to talk to each other across a campus. And those are some of the initiatives that we're working on there. We're also working on an age-friendly cities initiative, primarily in China. For those of you who might know, China, like many other countries in the world, is facing an age crisis in which a large portion of the population is going to be aging. There's a smaller cohort of younger people able to support those individuals. And so many governments are looking toward technology as a way to provide supports and care for people as they age without having to institutionalize them or to have them be kind of left stranded on their own. And we've been doing a considerable amount of research and working with both government and telcos and other kinds of organizations in China to see what we can do in terms of supporting that effort there. And finally, another big area is big data and analytics. So we've been working with folks like OHSU and other organizations to try to understand what needs are, particularly in terms of computing power and speed, as we rely more and more on genomics testing to understand what would be effective therapies for cancer and other diseases. How can we get to those answers quicker for people so that patients don't have to wait a long time, so clinicians aren't left in limbo, and we can really try to accelerate that whole process. And that's a huge, that's where our large computing efforts come in because of the amount of speed and computing power that's needed to accomplish those things. So before I go into the user experience, are there any questions that I could take from people about Intel and its involvement in healthcare? Okay, we'll see if any come up by the end. But let's go on now to user experience. And this is where my team comes into play. So I am a medical anthropologist, which means I was sort of classically trained in how to do field work and ethnography and interviews and all that kind of stuff. We also have working with us people who come from different perspectives. We have anthropologists, but we also have clinical psychologists. We have people who with more of an IT orientation, people who come from design, ethnography kinds of backgrounds, as well as people who are our visual people. And it's really helpful for us to have that kind of multidisciplinary approach. We all try to use similar methods, but having different perspectives gives us a different eye on a problem. And whether it's a variety of clinicians giving different perspective on a patient and coming up with a really solid care plan, same is true when we're talking about this kind of research. When you have different people looking at the problem, they come up with different solutions. We try to apply a pretty rigorous approach to the research we do. So we don't typically just kind of jump into something, but we really try to understand a circumstance before we go into the field. And that means we may look at academic papers that were done. We do, the ever-popular Google search to find out what other people have been doing. We really try to, as much as possible, understand the space so that when we create a research plan, we're focused. Because unlike, my time doing field work, as a graduate student, when I had, a year to be out in the field, our time is typically much more constrained. So we really need to hone in on a question and try to understand what it is that we're going to do and prepare ourselves for that jump into field work. So that's the first part. Then we plan. We plan our methods. We plan who we're going to be talking to. We plan a lot of logistic, just sort of the boring logistics of how we're going to get there and what are we going to do kind of stuff. But the planning piece of it is very important so that once again, when we get to a location, we can be most efficient and most or least disruptive to the people that we're working with. Because, of course, we have learned over the years that when you're working in a clinical environment, clinicians have about that much time that they can give you, so you really need to maximize that time, and patient care comes first. So we need to position ourselves in a way that we can learn what we can but not get in the way of what's happening for patients. So then we get it done. Somehow miraculously we spend our time out in the field collecting research. We do employ other methods besides just observation and interviews. I'll go into that a little bit. But we implement our research plan, whatever that might be, and collect the data that we have. Part of that also then becomes the harvesting of it. So we, in a traditional sense, we need to manage the data that we get, whether it's visual or transcripts, notes from our field work. We need to encapsulate those and make sure that we have them in hand as our data. But then we also work with not just the people who are out in the field, but other folks that we can bring in, like our engineers, architects, other people who have different perspectives beyond our research team, to huddle with us and to look at the information that we have and to see what we can come up with in terms of what do we think is important that's going on here and what kinds of things can we do to address it. So the harvest piece becomes very important, and it's our first opportunity to kind of disseminate what we know beyond our small group of researchers. And then the translation piece comes in. And at a place like Intel, that's very important because we need to speak to a variety of different folks. We need to speak to engineers who are thinking in terms of requirements. We need to speak to business folks who are thinking about, well, what kind of business model are we going to build around this? We need to talk to other groups who have maybe no interest in healthcare at this point, but we need to convince them that this is an important issue that needs to get on their roadmap, or that somehow we like to partner with them to create some solution. So the translation piece becomes exceptionally interesting, and I'll give you some examples of that in just a minute. So we like to think in our group, and we like to convince others that ethnography inspires innovation. And by that I mean when we go and immerse ourselves and bring back the stories of real people encountering real situations and difficulties, it helps people to become more creative in terms of the solutions that they provide. It's sort of easy to get some people who don't have exposure to lock themselves in a room and come up with some ideas, but whether or not they actually work in an environment is in large part dependent on how well they understand what the actual needs and the actual environments and contexts are that people are trying to work in. So once again, we go and spend a lot of time like this, observing what people are doing, trying to capture images so we can bring them back to the team that's not there. But really spending a lot of time and saying, what does it mean that all these people were clustered around that one computer? What does it mean that that person's writing something on a piece of paper as opposed to putting it into a tablet or a laptop or some other kind of device? How is all that impacting the kind of work that they do and the kind of work-life that they have? We conducted a study, and it's now close to a year old, and then we continue to add to it, but we had a large research project that we undertook to try to understand how mobile are healthcare workers. So we worked with some consultants to expand our team because we had, at the time, an even smaller team and an even shorter deadline to try to get some information together. So we did research in the UK, in Germany, in 2 cities in China and in the United States, and spent a lot of those times were concurrent weeks, but we spent a lot of time out in the field observing people in different hospital settings, following doctors, following nurses, trying to see what they were using and how they were getting about their work. We began the study thinking, well, let's shadow people who are using tablets or are using phones as part of their work. And we did some of that, but quickly sort of changed the research project to look much broader than that, at not just devices that people were using, but other kinds of factors within the ecosystem of the hospital that were affecting even a person's ability to be mobile. And what other kinds of things were they using to become mobile? So one of the values of the kind of work that we do as ethnographers is that we have that flexibility. It's not just like a random, oh, let's change things. It's considered, and it's an iterative kind of process, but unlike, say, for example, a questionnaire which needs to go out in a certain way in order for it to be valid and for you to collect the sample you need, we have that bit of flex within ethnography to say, there's something else going on here. How can we expand our horizons? How can we ask that question differently or ask a different set of questions in order to fully understand what's happening within this environment? And so we did a bit of that with the whole team, and because this was done, people who were in different places at the same time, we would often rely on blogging to each other, sharing photographs, doing that kind of stuff to really be able to debrief, because we had somebody who was on U.S. time and somebody who was on China time, and conference calls were not particularly practical at that point. But we were able to sort of feed each other information and have that change disseminate pretty rapidly across all of the field work that was being done. So just wanted to have a look here and at this particular photograph. And when we were starting to see things like that, we were seeing, again, we were looking for mobility, but then this is a busy ER in a hospital in Chicago. And all the patients are lined up here, and they're in those rooms. But all the staff is here because what they have to work with are desktop computers and cows or wows, depending on what you call them here. But again, that took them away. What we were seeing more and more is that because people had to go here to retrieve information and to document information, they weren't here at the bedside. And so how could we enable that, having people able to do things at the bedside and still get in their documentation? What we were seeing was that people were doing that, but the means that they were using to collect data here was a piece of paper and a pencil, which meant that when they'd have to go back and re-enter that data, so there was double work happening there. Or for those, other people would kind of retain it in memory and then go back and enter the data, which, as we all, I don't know what your memory's like, but it's a dangerous thing if I were to do that. So again, how can we really facilitate that whole process? So just a little bit more on methodology. When we talk about observation, it's really focusing on what's happening in an environment. And it's not usually just like 15 minutes in an environment, but it may be an entire day or a series of days that we spend to really try to understand what all the interactions are. We're looking at what individual actors might do, like in the case over here. This was the work we did with the VA. And we were shadowing doctors and nurses who actually went out and provided primary care in the homes of veterans. And we were trying to understand what that was like, what that experience was like for the clinician. And what we learned, among other things, was that was their workstation when they were in someone's house. It was that, or a footstool, or their lap, or some other place where they had to do it. And so the question for us became, what kind of devices can people use that enable them to work in those kinds of environments when you don't really know what the situation will be like, or even if you're going to have a place to connect, because in some veterans' homes, the wiring in the house wouldn't even support the kind of electrical needs that the provider might have. We also look at interactions between people and technology. This was a study we did up in Seattle where we were testing the use of Windows 8 tablets with clinicians in a pediatrics practice. And we were seeing how the doctors were actually incorporating them into their practice. So how are they holding them? How are they carrying them into the room? Were they showing them to the patients? And then how are they using keyboard devices to continue their documentation once they were out? In this case, this guy had a Bluetooth connection, so he was just like plopping his tablet next to the keyboard and able to use it. But those interactions between people and technology are another thing we looked at. So we've got people acting, we've got people and technology, and then we've got people in groups interacting, and how does that happen? That's another focus of our observation. What is it about the way that they communicate, the kinds of things that they use in the form of retrieval or recording of information that could tell us, again, something about what needs are. Here we have people trying to share information, like, again, these residents are carrying sheets of paper because they don't have electronic access to the patient records. They're carrying them along with them. Another interesting piece about this, which is, I think, not atypical in hospital settings, is that there's limited amounts of compute devices available for people to use. And so when you have 2 or 3 teams rounding in a teaching hospital and you have nurses who are distributing meds at the same time, it becomes an interesting cultural situation of who has priority, who access to those compute devices, and how do they negotiate who gets to use them. So those are all kinds of factors that we think about when we're doing our observation. There are times when we use other kinds of tools as well. We certainly use surveys on occasion, and we use things like other kinds of stimuli, photos, and other kinds of things to get at people's ideas of things. For this mobility project, we also conducted workshops with the doctors. And we asked them to do things like plot their day, what their day was like, and to overlay other kinds of things upon that simple timeline of what their day was like. What kind of devices they used, what kind of people they interact with, and what kind of emotions they were feeling. So we wanted to get at, what kinds of situations were stressful because of the presence or absence of certain kinds of technologies. And it's sometimes difficult to ask people those questions outright, and sometimes you can observe it because you see somebody getting mad and like slamming their laptop on the floor, but you don't always have those opportunities. So we need to come up with ways to get at what we hope would be observational, but is not always. And things like these workshops are usually a really good way of doing it because it gives people, gets people creative. It gives them something to play with, and so that untaps other parts of their mind. Sometimes working in a group is really useful for that because it kind of lightens things up for people. And what I like about these in particular is that people take them where they want to go. There are a lot of methods that you can use like this. But we have questions that we come into the field with, but we may not know the right questions to ask yet. And if you give people the lead and the research, they'll oftentimes come up with stuff you didn't even think about. And that's really useful for us as we modify our methods. So I mentioned that output is really important. And particularly I find in a place like Intel, creating tools that you can use in your dissemination process is really helpful. And we are very grateful for people we have who are much more visually oriented than I am and able to produce these kinds of things. Because these are the kinds of things that speak to the people outside of our group, within, and especially outside of our group as we try to tell the stories. So we try to do things like create personas. And this, I think, is a nicely done one in the sense that it gives you sort of the basic information about the person, and as well as maybe a quotation from them, the kind of tools that they use, and some more information about their work. The personas, for those of you who might not be familiar with this, are usually not a person, but it's a kind of composite of the people that you've been working with, and you create personas that are archetypes of certain kinds of parts or segments of your audience. But they are really helpful in terms of getting people to think about who it is that they're designing something for. They can kind of go back to these almost as flashcards and say, oh yeah, he wouldn't like that, or she would like that kind of thing, as they think about these as almost real people. We haven't done it, but I've heard in other places people actually construct life-size personas. I was at a conference recently and they were talking about this, and they just have them inhabit different parts of their workspace so that people always feel, oh yeah, I'm doing my work for this person, not for some abstract thing. We also try to create opportunity maps. So I mentioned a harvest session where we try to come up with some ideas and identify pain points. And we kill a lot of sticky notes in those process because we ask people to write down ideas that they might have, to identify pain points that they think people are having, and we wallpaper the walls with those kinds of things. And then through a process of consolidation, we really try to focus in on what seems to be the real issues here and to become creative with what are some of the solutions that we might apply to that. When you create those kinds of tools, you can often come up with an opportunity map, which you might, define sectors of it in terms of types of people that you're designing for, or on a scale from stationary to mobility, for example. But to really look at what are some of the opportunities in terms of solutions. And very quickly you look at solutions that are beyond where you intended to go necessarily. So like, as I mentioned, we were talking about tablets and looking at devices when we were talking about mobility and when we began this study. But it became very obvious by the end of the study that it wasn't just a device. It was about, connectivity. It was about, the software that enabled people to access or to retrieve information from a medical record. It was a much larger and rich ecosystem. And so we began to think beyond devices to services, to software, to other kinds of things that needed to be bundled together in order to create this better vision of the future. Usually within an opportunity map or in concurrence with it, you might do something like a SWOT analysis where you get strengths, weaknesses, opportunities, and threats. And it also helps you to identify, well, okay, maybe I want to make this change in an electronic health record, but what does that mean in terms of the regulatory environment and the environment of who is controlling EHRs and all this kind of stuff. So it, again, begins to open up your mind to possibilities as well as things that you need to do in order to get to your goal. So it can be very useful road mapping exercise. So I will conclude with this slide, which is kind of a collage of various research opportunities that we did, both in terms of the VA and primary care and the mobility research we did. And just reiterate that, we think that this approach clearly has value. And at Intel, we've been using ethnography for many years now. And it's sort of recognized company-wide that this has some value to show in terms of the kinds of ideas and the solutions that we come up with. I think it's a fertile area for anthropologists. I know that there are, as I mentioned, other people who are also involved in this kind of work who come from a variety of disciplinary backgrounds. But I think I encourage, for those of you who are thinking about methodologies for PhD work, you might want to consider something like a bit of an ethnography to help you flesh out your thought process. It sometimes works very hand in glove with more quantitative kinds of work because it helps to explain what's happening in one realm or helps you prepare for the quantitative. It has become much more acceptable in terms of a unique kind of or singular kind of research for dissertation projects as well. I'm happy to see that more and more journals are accepting research that's qualitative in orientation. So it certainly has come to rise in academic as well as more industry kinds of endeavors. So I think we have a fair amount of time for questions. So if anybody's got any, please pipe up. Yeah.
I think I'll start. Now, I also want to remind anyone who asks a question to push the button on the microphone in front of them so it gets recorded to the recording of this talk so that people who listen to it can hear it. The question I want to ask is that sometimes there's a little bit of a disconnect between sort of the user experience and focus on specific tasks. And one of the big tasks in healthcare and certainly in informatics now is, to use the buzzword, data analytics, people doing things with data. And one of the big problems with data analytics is the less than optimal quality of the data that goes into systems. So the question is, are you aware of any work or do you have any thoughts on how we can build systems that help users not only have a better user experience but also generate, but also collect good data for all the kind of myriad of reuses of that data that we hope to see, like quality measurement, those sorts of things?
I'm thinking of a few things. So one is improving the user experience for the data entry, and that could be making the interface, the user interface, more friendly or more customizable to match the idiosyncratic need of the particular clinician. We've noticed that people have their own way of doing things, and so an inflexible system sometimes leads to people just choosing not to do parts of it. The other thing that we've been talking about is different ways of getting data in. So if writing something down is too cumbersome, if keyboarding in is too cumbersome, are there ways that we can use voice, for example, or gesture, or other kinds of techniques in order to get the data into those things. Aligned with that would be the use of sensor data. So rather than having people take vitals and enter it in, can we do more about porting information directly into the EHR so that that information is there? And then the fourth area that we've been looking at too is for things like quality reporting, how can we use the data that is in there that may be coming from these more automatic sources and just be able to process them in a way that completes those fields, that fills in the information that you need without someone having to go in and do it. And I think finally too, having devices that are available at point of care may make a big difference too. Because if you're relying on someone's notes and then the recopying of it, there's a margin for error there. And then also if someone's remembering it, retaining it in their head, and then going back and documenting it later, pieces of it may fall out.
So you touched on participatory design when you talked about the workshops, and I know the students have been really interested in that in the past. I wondered if you could expand on it for us.
As I mentioned, I think it's a really useful way to tapping into information that you might not otherwise get, because it gives people the lead in terms of the research or what they tell you, and it also, I think, it's a playful process many times, and so it enables people to think about things in different ways. Instead of giving you sort of a standard face-saving answer, they might come up with something that's more creative and digs a little bit deeper into their own emotional pool. So I think that's useful. There are a variety of different tools that people use. So the format, for those of you not familiar with it, it's sort of like a focus group, only it involves people actually engaged, not just telling you things, but actually doing something with you or for you. Some techniques that people have used are called placemats. So they might give you a topic, for example, tell me about what your work life is like. And then there's an array of pictures and words and other kinds of stimuli that people can put together and create this placemat with all this collage of these different kinds of things. And then they go through and they explain different pieces of it that help to illuminate what they're thinking about. Sometimes we give people actual or pretend devices to work with. Let's see if I can get to this slide. That help them, to think kind of creatively and even play act. There. And this one here, we gave people who were part of a clinical team, right there, pretend devices. So we had like laptops, we had phones, we had tablets, we had all these different things that were just constructed out of paper. But they were meant to make people think about what devices they would use in a particular interaction. And in this case, it was about discharging people from the hospital and how to facilitate that. So it gives people things, again, to be creative with, stimulates some thought process on their part. And a piece we added to this is that they had to play act what the discharge would look like if they had these other tools. So we had people who were, pretending to be the cell phone or talking on the piece of cardboard. And once again, it gives you a different flavor for what people are thinking about and how you might go about creating a solution. So people have used a variety of different tools for them, but I think that they're really useful in terms of the hands-on and a look into sort of the emotion and the creativity behind things. Yeah.
I was interested to see your Post-it notes as you're doing your opportunity maps. Have you explored technology applications that might simulate that type of Post-it experience, particularly for people maybe that are collaborating remotely?
That's a great question. We have done some of that, some whiteboarding via link and other things with people who are remote and sending messages and things like that. We've also had people participate remotely by having them on a video camera and sort of sending by instant message their little sticky note that we put on the main wall. But at least what I have found to date is that there's something about that process of having them all on the wall and looking at them and collaborating on how you move them together into clusters that I haven't found a technological substitute for.
Kind of similar to the, the brainstorming with the dot priority. You get 5 dots and you can pick. I mean, there is something about the physical interaction and kind of seeing what other people are doing. And, yeah, we have tried doing the whiteboard thing remotely with resounding failure because it's hard. Other than staff writing on it, it was hard to get the participants to contribute.
And I think you have, as much as we all try to participate when we are remote, there's something about the accountability of being in the room that helps to focus people's attention, too. And so I think the participation and the creativity helps. It seems to work better that way, unfortunately. Yeah?
You mentioned you've been doing some research in primary care. Could you tell us more about that?
Sure. That's a little older research. It's a few years old now. But what we did in that study was to shadow primary care doctors in we were in 5 different cities in the U.S. And we spent a couple of days with each of them to try to understand what their workflow process was. Some of them were completely electronic in terms of their documentation. Some of them were still exclusively paper. But again, we were trying to understand what were some of the constraints to adoption of technology and how people who were the early adopters were using what they had. We also had the opportunity, as it turned out, to be at a couple of practices where people were transitioning. So we got to sort of be there with them in their pain as they were trying to convert the paper into electronic documentation. And that was really helpful for us to understand really just what kind of commitment it took for someone who was in practice for 10 or 15 years to make that transition and try to get all those documents electronically. So it was one of the things that I think we understood from that, too, is how idiosyncratic the documentation processes were in each of those offices. We had people who were using, either a homemade EHR or were trying to modify one that they'd bought off the shelf. Even people who were using paper records had different forms that they were using. We had one doctor who had created this big rubber stamp, and he would put it on a piece of paper and have these different fields that he would use. So, it makes us think about how nimble software needs to be in order to respond to people's needs. You have to have all this, there are criteria for what gets documented, and I think people go through medical school and learn certain ways of documenting data. But beyond that, there are things that people like to do their own way, and so how can we facilitate software to do that? Yeah.
Earlier, you had an image of a bunch of clinicians gathered around a monitor or screen. Has your work inspired the development of any collaborative technologies? And do you have any specific examples?
Well, I know we are working on some technologies to enable that. I'm not sure how public the MPOC stuff is, but we're working on some ways to help people. Well, we're looking at a couple of things. We're looking at leveraging existing kinds of software that we might use in a corporate setting to enable clinicians to talk to each other. But we're also looking at some other things where we could embed software in devices that would facilitate, video conferencing and audio conferencing and leaving voice messages and things like that. So yeah, we're trying to comprehend that, but we're still in the works on that one.
I think that going into these places and doing this kind of research with these kind of methods would lead to being surprised a lot. And in a way, that would be, one of the best outcomes, right? And is that true? And can you tell us a couple of examples of your favorite surprises?
Sure. Yes and no. I mean, I think that there are occasions of surprise, but particularly when we do a larger scale study or do it for a longer time, we begin to pick out patterns and see some consistencies in terms of what the needs are across all those different settings. In terms of some surprises, the picture that I showed you of the doctor who was keyboarding on a chair, I think that was a new exposure to me, particularly, to do that kind of research in home care. We shadowed home health nurses and some other folks who have delivered care in the home. But this is a program that the VA has that provides all of primary care to people, to qualified veterans in their own homes, so they don't have to go into the clinic. And I think it was a combination of the comprehensiveness of the care that was being delivered, as well as some of the circumstances that the veterans found themselves in, that it was really enlightening to see what people were contending with, well beyond just like the normal part of doing a blood draw or checking someone's vitals, all these other kind of psychosocial and environmental things that people were dealing with as they tried to do their job. And for folks who had laptops that couldn't even hold a charge for more than 4 hours, it was like, how could we expect them to bring that into these environments? There were a lot of other questions, and so that was a really eye-opening experience, I think. And I have done research in hospitals as well, and over the years, the technology changes, of course, and so what was a problem 5 years ago is not a problem now, but there are new problems that were created by the fixes for the old problems. And so I think we always have to go in there with fresh eyes and not assume that we know a situation because we were well-grounded in it a couple of years ago even. So that's something that we have to remind ourselves each time we go in and not get too jaded or too complacent in terms of what we're looking at.
So, I think the qualitative research that you do, provides a really unique perspective to a lot of situations. But sometimes, the quantitative piece can add value as well. Mm-hmm. Have you done any sort of mixed methods where you've tried to integrate the two and had any success? And do they agree? Do they disagree?
Mm-hmm. We have. And I did a lot of that when I was at Kaiser. We did a lot of mixed methodology work. So it does work. A couple of ways that it does. More currently, we might conduct surveys of clinicians to understand, what they think are their pain points, and that helps to guide us when we go out into the field. So we kind of know what questions to ask or what things to focus on. So it's sometimes a very good precursor to the work that we're doing. It also helps us when we're doing more what I would label usability kind of research, where we might, actually have tasks that people do and quantify how they're doing it and the speed at which they're doing it. So once again, that's a very good connection between the two. I've also used qualitative research to help understand what's going on in quantitative research. So we might get some results and say, what's going on there? I don't quite understand that, or I want to dig a little deeper here. And that forms the basis for the qualitative research to follow up on that and help us to understand that a little bit more. So I think they work very well together. Yeah.
Okay,
All right.
well, thank you very much.
Thank you. Appreciate you coming.